شكرا جزيلا دكتور احمد. I'd like to introduce our next speaker. عضو مجلس اداره الاسما دكتور اسامه الدينامو بتاع الجمعيه، اللي كل ما نزلنا نقول اسالوا اسامه هو يعرف يتصرف يعني على طول. دكتور اسامه رجب هيكلمنا على different case scenarios for hypothyroidism. اتفضل يا دكتور اسامه.
ثانك يو. النهارده هنتكلم على different case scenarios in hypothyroidism. طبعا بس انا عايز اقول للدكتوره ميادة حاجه، هي بتقول لا قدر الله هير فول. هير فول ده حاجه زي الفل، مش يعني اوكي تمام. النهارده هنتكلم على different case scenario تخص الهايبوثايروديزم. My scenarios for today lecture. TSH is high and I feel good. في discrepancy ما بين symptom and the lab. TSH is always high. Treating the patient and the TSH is still high. Thyroid and new drug description. Is there an association or not? TSH in new mother. واحدة عايزة تحمل. TSH my grandmother. TSH عالي بس في سن أكبر شوية. My thyroid pill is not available. دي السيناريوهات اللي هتكلم فيها النهارده. الترند الموجود النهارده بقى. 35-year-old female presented to her GP anxious due to abnormal thyroid profile. عملت thyroid profile screening وده غلط. Screening thyroid profile طلع abnormal. She was not on any drug and there was no family history of thyroid disease. Her general physical and systemic examination was unremarkable. Thyroid function is as follow. Free thyroid hormone, free T3 were both high. TSH is also high and she didn't complain from anything. Which of the following is appropriate? Commence carbimazole and consider this hyperthyroidism. Commence thyroxine and consider this hypothyroidism. Consider assay interference. في حاجة غلط فهنعيد تاني. Genetic test for thyroid hormone resistance, which is very rare by the way, or urgent MRI for pituitary considering TSH OMA for example, and by the way it is rare again. In this condition, the first step always is to consider assay interference. دايما صدق العليل وما تصدقش التحاليل. Believe the patient, not the lab. البيشنت بيقول لك انا كويس. اي discrepancy دايما consider assay interference. ايه اللي ممكن يعمل assay interference؟ حاجات هنقول two example منهم زي المايكرو TSH, enterophilic antibody, a large amount of auto antibody present in the circulation that may interfere with the lab, biotin زي ما الدكتوره ميادة قالت النهارده, or anti-streptavidin antibody, the molecule that is used for detection of TSH or thyroid hormone or many hormone, by the way. If we consider assay interference, always repeat the lab in different lab using different technique. The normal or the usual method for detection of the thyroid hormone, what we call the sandwich technique. The analyte here or the hormone in green, which is connected to the capture antibody and to the signal antibody. As if we have in two arms. One arm is connected to antibody and another is connected to antibody, and according to the level of signal, we have the level of the hormone. What is the problem in presence of heterophile antibodies? The heterophile antibody interferes with this and becomes sandwiched between the capture antibody and the signal antibody, and this will be read as excess hormone, and actually the TSH is within normal. So it may give a high level of TSH while the patient is still euthyroid. The same for macro TSH. TSH become bound to immunoglobulin, giving a large molecule, which is called macro TSH. This macro TSH is biologically inactive. Remember the macroprolactin. كان في محاضرة اسمها macroprolactin, and a common scenario to have a very high level of prolactin and it is inactive. The same here in TSH, and the patient will have high level of TSH, but it is a macro TSH, non-active TSH, and again it may give us a false impression that the patient has hypothyroidism. We may treat the sample with what's called polyethylene glycol, a heavy substance that will accumulate the excess macro TSH in the bottom and the monomeric TSH, the active one, will be read as normal. This is the first case. Second case for today, 22-year-old female presented to GB with weight gain, lethargy, and cold intolerance, hypothyroidism. She had a history of primary hypothyroidism for which she was taking levothyroxine dose 150. She also had bronchial asthma for which she was on LABA ICS, long-acting beta-2 agonist, together with inhaled corticosteroid. The free T4 is within high normal, free T3 is within high normal, TSH is high. What of the following may explain this? هل counsel here for compliance? In the first scenario, I told you that to believe the patient. Here, not to believe the patient, ما تصدقش العيان ولا increase thyroxine dose. هconsider ان في مشكله فهزود الدوز ولا reduce the thyroxine dose, repeat the thyroid function again ولا switch to T3. The issue always don't believe the patient. انا كل مره بقول مره believe مره مش believe. لا، الفكره كلها ان احنا دايما when there was discrepancy in the lab, always ask for adherence. Is the patient taking his pills or not? Poor compliance may lead to discordant thyroid function test. As in this case, there is high normal, free T4 and T3, but the TSH is still lagging. TSH is still high. And this may explain this. Patient try to normalize his lab by increasing the dose. هو عارف انه رايح مثلا لدكتور ايهاب بعد اسبوعين انا هزود الدوز كتير قوي عشان ايه ما يزعليش for example. Also remember to educate the patient how to take his medication right. Thyroid hormone need to be taken on empty stomach away from any supplementation, especially calcium and iron. If the patient is on the full dose of thyroid hormone, which is 1.6 per kilo microgram per kg, and the TSH is always high, ask for adherence issue. If the patient is okay with this, if the patient adheres to his medication, try to find other causes that may interfere with the absorption, such as celiac disease. If I still not sure with my patient, I have to do direct observed therapy. يعني أخليه ياخد الهرمون بتاعه under my observation by giving what's called thyroxine absorption test, giving him the full weekly dose of the thyroid every week, and then measure the TSH. If it is normalized, thus it is an adherence issue. يبقى المشكلة ساعتها في العيان بتاعنا. The third idea or the third scenario, 40-year-old man was referred to endocrine clinic with symptoms of malaise, weight gain, and cold intolerance, يعني hypothyroidism, autoimmune hypothyroidism, taking levothyroxine by dose of 75 microgram per kg for the last 6 years. He had been diagnosed with pulmonary TB and started by anti-tuberculous medication, which included INH, isoniazid, rifampicin, ethambutol, and pyrazinamide, the quadruple common drug. The free T4 is low, TSH is elevated, the anti-TBO is positive. She is diagnosed with autoimmune hypothyroidism. What is the explanation of this finding? Is it flare-up of autoimmunity with TB? TB may induce autoimmunity. Thyroxine interaction with either ethambutol or INH or rifampicin, or it is a poor compliance again. I think from this scenario, and then we have 4 drugs. One of them may act as an enzyme inducer. What is enzyme inducer? That increase the metabolism of drug, and thus we may need higher doses of the thyroxine. Here, rifampicin is hepatic enzyme inducer that accelerate the metabolism of some drug, including the levothyroxine. His thyroxine dose need to be increased to overcome this problem. There are a huge list of drugs that may cause many abnormalities in thyroid function. However, if we concentrate in the second column, some drugs that increase the clearance of this drug, increase the metabolism, and one of them is anti-tuberculous drug, such as the rifampicin. The fourth scenario, 25-year-old female reviewed in the endocrine clinic for follow-up. She had a background history of primary hypothyroidism and was taking levothyroxine. She remained well and was not on other medication apart from thyroxine. On examination, she was well but she planned to start family. She need to be pregnant. Her thyroid function is as follow. Free thyroid hormone 14.5 was normal, the same for free 3, but TSH is again was normal, not elevated. What to do? جايه thyroid function normal. What to do? And she wants to start a new family. Add leothyronine, start T3, not commonly used. Continue same dose of thyroxine. She is okay. She is well to continue, or increase the dose of thyroxine. And why? To reduce the dose of thyroxine. And why? Or to switch to leothyronine and stop. The TSH is not okay in this scenario. Why? Because according to American Thyroid Association in 2017, if we preparing a female to get pregnant, to bring down the TSH to 2.5. In Egypt, we don't have country-specific TSH, so we depend on previous guidelines that we use the thyroxine or TSH levels to 2.5, and if we continue pregnancy, I will show you the other level. In this particular clinical scenario, preconception TSH is higher. Okay, it is above 2.5. It was 4. As a result, the thyroxine dose need to be higher for 6 to 8 weeks. And this was explained in the American Thyroid Association in women who plan to be pregnant to use the 2.5 level as a reference number. If a woman found herself to be pregnant before or during her contact with her doctor, try to increase the dose by 20 to 30%, or practically to add 2 pills to her usual dose at the end of the week. This is the levels of the TSH, the trimester specific range, and this was from the previous guideline. In the first trimester, the upper reference is 2.5. In the second and third trimester, the upper reference range is 3. How frequently to monitor hair? We have to monitor hair more frequently, not every 6 weeks, but every month till the mid-gestation, and then see hair every now and then in the last trimester. My fifth scenario, an 85-year-old male with hypothyroidism presented to his GP with lethargy and poor memory. He was taking his medication regularly, and the latest dose of levothyroxine was 75 microgram. His general physical and safety examination was unremarkable. He didn't check TSH for many years, and you checked it, and it was 6. Which of the following is the most appropriate next step for the management? To increase the levothyroxine dose to target TSH below, or commence leothyronine, or consider non-compliance, change the levothyroxine brand, or continue the same dose and search for other cause of dementia. What to consider here? The level of TSH in elderly sometimes differ from the middle age. Treatment should be initiated at lower dose and slow initiation and titration of the drug to bring down the TSH, but not to the usual TSH value, مش زينا. Normal serum TSH range are higher in elderly patients, thus higher serum TSH goals may need to be achieved. The ETA suggests raising serum TSH level in the elderly, not using the usual TSH. This figure and this table show that in elderly and with advancement of age, the TSH value become more high. The American Thyroid Association tell us to adopt higher TSH value while treating elderly patients. The last scenario, a 44-year-old female with a diagnosis of hypothyroidism and was referred to you for a follow-up review every 6 months. She mentioned that she didn't find her important hypothyroidism pills. مش لاقيه الإقراص بتاعت الايه؟ الثيرويد. She had been taking levothyroxine under the name of blah 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 whatever, and for the last 10 years she was on a stable brand. Her TSH is within normal range. You convinced her to take any available brand. انت قلت لها خدي اي حاجه. لان ده السيناريو بنشوفه كتير. ايه اللي نعمله؟ What to do next? هل to increase the levothyroxine dose and consider it Egyptian؟ اعتقد في بعض الناس مش عندها ثقه في البراند بتاعنا يعني. طبعا لا انا بقول or wait for a good brand, commence same dose and see here again in short interval. انا بشوفها خلاص احنا عارفين ان احنا while monitoring patient with hypothyroidism to see them within 6 weeks, then within 3 months, then we may see the patient every 1 year or twice a year. Here I will convince her to come after short duration, all of the above or none of the above. طبعا a common scenario nowadays to have this message on our WhatsApp. I didn't find my pills. What to do? إيه اللي هنقولها لها؟ We have many available brand. Find any brand and take it. Okay? According to the American Thyroid Association, they stress on this point that we need to stable or to continue on the same brand or in the same generic while monitoring our patient. Why? Because the different bioequivalence of the available drug and the level of recommendation is different. It is strong for those with childhood hypothyroidism, those with thyroid cancer, those who are pregnant or those who are frail. But it is weak recommendation for general population. Of course, I will try and put this in breaks كده. We will try to continue on the same brand, but we have an issue for this drug and we have to shift to another brand or another generic. And again, the American Thyroid Association tell us if we continue on different brand or different generic is to monitor the patient on more frequent duration, as if I started from zero. Yani, I will start to monitor them after 6 weeks, then 3 months, then 6 months, then yearly or twice yearly. To sum up, those are my ideas for today. Consider lab interference if there is a discrepancy between the patient symptoms and the patient lab. Adherence is always the answer if TSH is always high while you're monitoring your patient. Many drugs may impair the levothyroxine, so search for the drug and look at the drug bag of the patient. The answer may be there. TSH is below 2.5 in childbearing period. TSH is old in elderly. The levels of TSH will be high in elderly. Consider any available brand or generic of levothyroxine while treating your patient. I think كفايه بقى ولا كمان واحده يا ريس؟ كفايه بقى. And thank you.